Yes, Ritumar.
Yes, sir. So good evening, everyone, and good evening, sir. We are back with our next session that yesterday we took the part one for the applied biomechanics for the cervical spine. And with connectivity of thorax and lumbar, we have also added some points in that also. But today we are going for the applied biomechanics because as a clinician, it is very much important to understand the importance of the biomechanics, how we use as a movement testing for our patient or as a different diagnosis, differential diagnosis, we utilize this biomechanics for the testing so that we can clarify that what is the cause of the patient, the pain, either the pain is in the thorax or the pain in the lumbar spine, which is influenced to each other, or maybe there's a compensation is taken by the another region for, because of the tightness, if there is a articular dysfunction, so because of that the hyper or hypomobility of the ligaments, or if there is a myofascial, so tightness or adhesion or the spasm of or overactivity or underactivity of the muscle, or maybe there is a because of the compression forces there, the radiculopathy, stenosis, these can be with the disc herniation or with the facet joints giving the foramen narrowing. Because of that the patient is getting the symptoms of the numbness and the tingling. So it is all about that the spine where the compensation can be taken by any region for the other region to give the support to the patient functional activity. So today we are talking about the thorax, which is also a very important part, because as a clinician, we see that sometimes the patient is having a pain in the cervical spine, but we give mobilization or manipulation to the cervical spine. After that, the patient feel more comfortable. It means the role of the thorax, maybe with the upper limb activity itself, the thorax plays a major role, or sometimes because of the hypomobility of the thorax, when the patient is doing the cervical flexion or extension, that time the thorax also takes part in that movement. So it means there is a hypomobility of the thorax also, that it is also moving with the cervical spine. So these are the things it is very important to find out with the biomechanics of the thorax, where the functional limitation of flexion and extension are there, or the mainly we check the thoracic spine with the rotation. So for that we are going to understand the biomechanics of the thorax with the other structures which are completely related to the thorax, that are also a very important part of our understanding of the biomechanics of the thorax. Because in this we can say that some structures which are also plays a very major role, like the sternums, ribs, these are also a very important part of the thorax region. Because I will say with the thorax, if the patient is having pain the posteriorly, we check the with the palpation of the spinous process. And because in the thorax we know that the how much importance of the ribs plays a major role with on the functioning of the thorax also, because of the posterior side, the costovertebral joint that are also attached. Because of that, the thorax region is a different from the cervical and the lumbar spine, because in that there is a another facet joint that is called as the demi-facet joint, which also the ribs articulate in that joint. So this is the way if the patient is having a pain with the breathing pattern is in a disturbed matter, that time also we know that the ribs also plays a major role. Because whenever we check with the movement testing, we check the vertebral column, but when we check with the breathing, we check with the ribs function. Either the ribs are maybe the muscles which are in the ribs, they are in the tightness, or maybe the diaphragm that is in the tightness. So these are the things whenever the biomechanics comes for the thorax, we cannot forget to understand about the biomechanics of the core muscles which are also attached with the thorax, or the diaphragm, or we cannot forget to check the ribs dysfunction, sternum dysfunction. So or their biomechanics also influence in the thorax movement. So because of their dysfunction, the patient is not able to perform their activity. This is I have taken some screenshots are from our the course of AOMPT, the Thoracic Manual Therapy Specialist course. This course is also a very important course, which has given us all of us the very new thinking process, that how we move towards the thoracic spine by evaluation itself in the standing position, sitting position, with the flexion, extension, or by movement testing with the spinous process of thoracic spine. Or we can say that the differentiation between the the spinous process placement itself is a different with the rule of the threes, or we know that the starting spinous processes, how we see that their movement, we check that their process, that they are in a elevated position, and after that these are in a oblique position. So it means that it is giving the support to the patient to lying down position, because if it will be also in a elevating position, patient cannot, or we cannot lie down on the bed also. So this is the biomechanics of this thorax is made like that, so that we can easily lying down, or as well as whenever the patient is having a thorax movement like the extension and flexion, or sometimes the patient is having the kyphosis is more than the normal range, that time also we check with the spinous process how the asymmetry is coming in the spinous process, or as well as if the patient is having a scoliosis. So that time these spinous process as well as the ribs, that time plays a very major role when the patient is having a scoliosis. So according to convexity or concavity, that time we check that how the ribs biomechanics is affecting to the patient either with the movement or with the respiration. So this is the way we always evaluate all the things, because this is a more bigger part in the spine from cervical to lumbar. We can say that the thorax is covering the bigger part. So it means because of it is the attachment with the ribs also, or because of that rib cage that is giving the protection to the lungs and the heart, the visceral organ, or as well as I can say that the diaphragm, which is the most important part. The diaphragm is whenever the patient is having any dysfunction, if we work on the diaphragm, because it is a completely related to the breathing pattern. So either the patient after the COVID, they are having a problem with the exhalation or inhalation problem according to obstructive and the restrictive. So that time also the thorax or the diaphragm plays a very major role to treat that type of patient, because whenever we are going to treat the patient for the thorax, we cannot leave only just checking the spinous process. We have to see the, because we differentiate the thorax working itself with the breathing pattern. So it means how much importance of this. So in this course, which that sir has explained all in the detail, that how we can evaluate, how we can differentiate with the movement testing in the sitting position, how we can taking in the flexion position, where if the patient is doing the cervical spine flexion is going on, if the thorax is also moving with that. So it means that how the hypomobility is playing a major role in that particular joint, because of that the thorax also moving. Or if the arm elevation is going on after that 80 or 90 degree, if the thorax is also moving, so it means that how the thorax working is affecting the cervical or arm elevation, or as well as the cervical working. So it means the relation is completely correlated, because upper ribs are completely attached with the cervical spine, which we all know, like the primary muscles of the scalenes, that is also attached with the rib, or that plays a major role for the lifting the first or second rib according to scalenus anterior and the posterior. So it means that relation with thorax and the cervical, we cannot evaluate separately. We have to check both the things. Either the patient is having a cervical spine problem, then I cannot forget to check the thoracic mechanism also, biomechanics. Or if the patient is having a thoracic dysfunction related, so we cannot forget to check lumbar or cervical biomechanics also. In that we can keep in the flexion or extension position, either with the cervical with the sitting position or with the standing position for the lumbar spine also. So this is the way this course has a very, I will say this is the very beautiful course of our AMPT, where we learned so many different things about the thoracic spine with the dysfunction related to ribs, sternum, intercostal dysfunctions. So this is the relation with the how the hypermobility of thorax or the laxity, instability of these spine plays a very major role in the patient. Posture related, if there is a because the tipping, the posterior, the tipping of scapula itself, because of the attachment of the thoracic spine, the patient feel the tightness in their scapular region also, because of the pulling forces working on the scapula, because with the tightness of the thoracic spine. And this also in this movement testing in the flexion and extension position, because it is very important when we are learning about the biomechanics to understand the movement testing of flexion and extension of the thoracic spine, how we evaluate in the sitting position with the rotation of the thoracic spine, how we do it. So this is nobody can explain in a such a easy way like in AOMPT we are learning, because in this also that sir how we make extension position, flexion position, or how we can check that how the spinous process when the extension is going on, so the space between the spinous process reducing, or when the we are checking with the flexion position how the spinous process the space is increasing, or in that also with the thorax how the intercostal muscles or which are also attached with the ribs, external or internal costal muscle, or as well as the ribs articulation with the vertebra. So if the movement is in a tight position, hypomobility or is there, so it means there is a vertebral, the costovertebral joint will plays a very major role when we palpate them. Or if the patient simultaneously patient is having a breathing dysfunction, so how the ribs movement we will check with the palpation of that costovertebral joint with the inhalation and exhalation. So that is also in this course sir has explained us in a very such a sequence way that with the dysfunction related, or how we treat with or how we manage this type of dysfunction. And this is all that we in recently our in some sessions where the pre-congress sessions of the CHIROCON 1, where the sir has also explained with the movement testing or the regional interdependence of the thorax, how the biomechanics of thorax itself influence the cervical spine or the lumbar spine also. So how we can check in this pics also, you can see that how sir has made the thoracic spine, all the ribs, that how it is attached or how it is moving in the, if there is a lateral flexion is going on, so how the articular process, the superior or inferior articular process gliding on adjacent vertebra. So this is the thing how AOMPT provides the simple way of learning to the students, that you can easily by seeing this, why I took the screenshots in this session, so that you people can easily understand that what is the uh, base of our AOMPT, from where we start our learning and where we land last in the that practical demonstration session, and where from where we are starting. It means that we work on first the base, after that we grow the crop, and then we see that how the fruits are coming on that particular tree. So this is the beauty and this is the glory of AOMPT. But because of that, I added the screenshots for all your reference also, or all, as well as you can easily understand that how the thoracic spine is influencing the cervical spine. If the patient is having a giddiness with the movement of the neck movement, so how we can check with the rotation of the thoracic spine also. So this is the way we correlate all these things, or if sitting to standing, we differentiate between the lumbar spine also. So this is, we can differentiate that thorax regional interdependence on cervical, or the cervical or lumbar spine pain on the thorax also. And this is that thoracic vertebra characteristics, which by before going to the biomechanics, this is also, I will say that very important to understand that how the vertebra of that thoracic spine, as we can see it like that, because in the presence of the articular facets on vertebral bodies for the ribs attachment. So because this is different from other side, because there is a attachment of the rib, and the long and thin spinal process directed backward, like which I have already shown that how the backward and then the downward in relation to the motion segment, or how they are overlapping each other in the sequence. So the tip of spinal process lies posterior and inferior to the body of the vertebra, and it is act as a lever to rotate the vertebral body, and results in the gliding, like in this also the gliding of the facet joint during the flexion extension, like in yesterday session we saw about the cervical spine, that how the inferior articular the facet joints, where the inferior articular facet joint glide on the below the vertebra superior facet joints articular process. So this is the same way in the principle are the same for all the segments, like in the cervical, thorax and the lumbar. Same like the transfer processes are gliding in the flexion and extension, the same will be the same. But in this one thing is the different, that is the articulation of the rib with the costovertebral joint, that is also we known as a demifacet joints, that is the different from other regions. So this is the way in this pic also we can see that these are the transfer costal facet joints from where the rib articulation takes place. So it means when the patient is having exhalation problem or inhalation problem, that time these costal facet joints plays a major role, or as well as the muscles attachment, myofascial attachment for the kinetics parts with the internal costal muscle or external costal muscle, that are also plays a very major role in the inhalation and exhalation. And this is, and if I will talk about the biomechanics of the ligaments, that also plays a very major role in the flexion and extension, how the load is taken by the posterior ligaments and the anterior ligaments, that is also, and in between the spinous processes, there are the interspinal ligaments in between the two spinous process, as well as the supraspinous ligament and the infraspinous ligament and the ligamentum flavum. So these ligaments are also whenever the thoracic spine or whatever the vertebra is going in the flexion and extension, that time one side of ligaments getting the compression, like in flexion anterior or the posterior, they will get the stretch position. They will be in the stretch position. So this is the way the all the vertebral level, the flexion extension give compression and stretch to the ligaments which are attached there. So this is like in the thoracic vertebra, or we will say that the primary characteristic feature of this thoracic vertebra are the costal facets for the articulation for the ribs. So that is the only the difference between cervical and the lumbar spine. And these are also that costal facets, you can see that are present in the transfer process for the articulation with the tubercles of the ribs. T11 to T12 have no facet because they are the false ribs and the floating ribs, and the spinous are long and inclined downwards. The vertebral foramen is small and circular. The body is medium size in the shape. And these are the costal facets are present on the sides of the vertebral body and for the articulation with the head of the ribs. So it means that this is the difference between the transfer process and the costal facets. They are extra here for the articulation of the ribs. And ribs and their attachment, if we talk about their biomechanics, that how we are moving towards, so it must be considered like in the physical examination, the movement during respiration moves with the complex combination of the flexion extension with the pump and handle motion, the movement of pump and handle, and the bucket handle movement in the abduction adduction, and in the caliper like motion in the internal and external motion, sorry. So in this also you can see that the pump and handle movement, that is whenever we see the biomechanics of the spine. So the elevation of ribs is if there is a pump and handle movement, so it increase the anterior posterior diameter of the thoracic cavity, or if there is an elevation of the ribs like this, if the pump and handle is like this, there is an elevation of the ribs. So it is anterior posterior diameter is increasing. And if we are talking about the bucket and handle, like just like a butterfly pose, so the how this is elevation is coming, the lateral diameter of the thoracic cavity is increasing. So we see the biomechanics of the thoracic spine with the relation with the ribs, with the pump and handle movement, or with the bucket handle movement. So that is also very important to understand their movement, because we cannot say that we are just checking the thoracic spine, the spinous process, or we will see the vertebral bodies which are attached. But these movements also influence the thorax activity. If the patient is having any ribs dysfunction, sternum dysfunction, after that, or maybe the patient is having any lungs dysfunction, because of that the breathing pattern is disturbed. So in this also we have to check all the thorax as a holistic approach, where we cannot leave this type of movement also for the ribs attachment. So in this, the upper ribs, pump and handle, bucket handle motion. In the middle ribs, primary bucket handle motion. And the lower ribs, mainly the caliper-like movements. And in the rib, one moves during the inhalation by anterior, posterior, and the medial scalenus muscle. Because we know that the first rib and the second rib, that is also attached with the scalenus muscle. So in this also, you can see in this model also. These are the ribs, first and second rib, and these are the scalenus posterior, medial, and the anterior muscle. So these are also attached with the rib. So they are for the lifting the rib. So it means they are also a part of the breathing, the scalenus muscle. Or if we talk about the sternum, so there are the pectoralis major muscles, major and minor, that is also for the breathing, that is also attached with the ribs. Or if we talk about the sternocleidomastoid, that is also attached with the sternum, so that is also plays a very major role. Or in the if we go downwards, so there is a transfer the rectus abdominis, that is also attached. Or we can say the diaphragm, that is also attached. So these are also as a kinetics of the thorax spine. We cannot leave these things, not the ribs, not these muscles attachment, or the diaphragm, that is also a very important. The function of the diaphragm, if the diaphragm is tight itself, the patient movement will be restricted in the thoracic spine also, because of their attachment is in the base of the sternum, so where the diaphragm is attached. So this is the way we differentiate all these things with the according to their biomechanics, how they are moving. Either the patient is having while doing exhalation, they are having a pain in their ribs also, or inhalation, they are not able, they feel pain in their thoracic spine. So how the elevation, how the flexion extension influencing the ribs dysfunction, or how the biomechanics of the rotations of the thoracic spine, the patient is getting pain. That time they are feeling pain in the ribs, or maybe in the internal, the costal muscles, they are feeling tightness there. So this is the way these biomechanics also very important. All the movements, not only the flexion extension, the movement of the thorax with the influence of the muscles which are attached to that part. This is also in that course that sir has the all the evaluation of the ribs, how we can move towards the rib anteriorly, posteriorly, where the costovertebral joints plays a very major role. Or if I will talk about the breathing dysfunction, so how the ribs movement itself, the like the pump and handle or the bucket handle movement of the ribs, we check with the biomechanics of the thorax spine with the simultaneously movement testing of the ribs. So in this also that sir has explained in fully. In some pics you can see that how that sir made that costovertebral joint within the posterior side if the patient is having a pain with the movement. So the pain we assess with the vertebral column, or if the pain with the breathing we consider with the ribs. So because we differentiate between that, how the pain is coming from the vertebral column, or the pain is coming because of the ribs, because the patient is having a obstructive problem or restrictive and problem with the respiration. So in this also we measure these ribs dysfunction also, or the mechanism or the biomechanics of particular ribs, how it is behaving in exhalation or inhalation. So in this biomechanics of thoracic spine and the rib cage, they both work as a single unit, because they both are completely closely attached with each other, and it provide capacity for respiration as well as for the circulation. And in this also we divide into a 4 region according to the biomechanical differences, like vertebral columns of the thorax with the manubrial region, where the C7 to T2 we evaluate with the cervical spine influence, because in this the C7 to T2, the movement of the extension flexion is matched with the cervical spine movement, like with the lateral flexion or with the ipsilateral rotation. The same movement like in the cervical spine, it matches with the thoracic spine also. Or if there is a vertebrosternal region like T3 to T7, where the attachment with the sternum, so in that also we see that the pump and handle movement motion biomechanics of that. Then also we check with the sternum movement, and as well as for the thoracic spine by keeping our hand in the both sides. That time we also evaluate the mechanics of sternum. And if there is a T8 to T10, there is a vertebrochondral region where the chondral part plays a very major role. Or after that, there is a thoracolumbar region that also plays a very major role, where the T11 or T12, that is the floating ribs. So that not that much, they are not much influenced to the ribs working, but they are attached with that, how the lumbar spine, they attach with the And after that, there is a thoracolumbar fascia that is attached. Because of that, the lumbar spine dysfunction, or the patient is having a pain because of the lumbar spine, either with the vertebral column or with the spinal process, whatever the dysfunction related to the lumbar spine. So that influence this T11, T12. For that, like we give the sympathetic slump position, where we mobilize this T11, the T12 ribs also, so that after that the patient feel comfortable. It means that the influence of thoracic to lumbar is the T11, T12, that is also closely related. So we can treat both simultaneously. If the patient is having a lumbar spine problem, so we can treat the thoracic spine in the maybe in the sympathetic slump position itself, or maybe in the slump position, because of sympathetic ganglia is present there. So we add all these things also. So their mechanics also influence each other working. If the patient is having a more kyphosis, so it will also affect the lumbar spine, the lordosis also. So these things also we see as a full part of the spine. So we cannot separate one part, like not only to the thoracic spine, we have to relate all these part also and then check. So this is the biomechanics of the thoracic, like the kinetics, where the thoracic region is subjected to increased compression forces. Compression with the like the cervical region, because it is the T1, T7, C7 and T1 is closely related, and they compromise with each other. So in this also, the cervical region, the compression with the cervical region, because of the greater amount of body weight that needs to be supported at the region like the kyphotic shape, because the cervical, the load of this cervical spine itself is taken by the thoracic spine, because sometimes the C7 and T1 is closely, sometimes we cannot differentiate between, because that is also when the upper lower cervical flexion we do. So we see that sometimes the T1 also getting in the flexion position. So that is also, it is that how the mechanics of T1 to C7 is different, how we have to check the movement testing. With the patient is doing the jaw movement, then we can check that either the C7 is only moving or T1 also moving. So this is the way in the kinetics also. In this also, we can see that the forces, like in one part there is a tension is coming, and another part there is a compression is coming. So this is also the greater flexion is at the peak of the kyphosis as a result of increased movement of line of gravity with the cervical spine also maintained by the kyphosis of the thoracic spine. And this is the osteokinematics of the thoracic spine. In this also, the zygophysial articular facets lie in the frontal plane, because and from T1 to T6, and therefore the limit flexion and extension in this region, because they are in a frontal plane. So the it will limits the extension and flexion. But in the articular facet in the lower thoracic region are oriented more into sagittal plane, which provides the extension and flexion in compared to T1 to T6. And after that, the ribs and costal joint restricts, because it is attached with the costal joint. So it will restrict the lateral flexion in the upper and middle thoracic region. But the lower thoracic segments, the lateral flexion and rotation are relatively free, because these segments are not limited to the ribs. So this is the differentiation in the biomechanics of the T1 to T6. After that, and in the last ribs, there is a little lateral flexion is also available, or in starting the extension flexion is little the less than the middle region of the thorax, because of the zygophysial joints are in the frontal plane. But when they are coming in a sagittal plane, the extension flexion movement is getting easy. So this is the way we can also see that in the biomechanics of the thoracic spine itself. T1 to T12, it is divided into the three parts, where in some area there is a rotation restriction, some area there is a extension flexion is restricted, or in some area there is a lateral flexion is restricted. So because of the presence of that particular the articular process itself, from T1 to T6 for their frontal plane present, or T6 to T12, T7, after that T10 they are in a sagittal plane. That time the flexion extension can come, but in the last where the lateral flexion restricted, because there is a presence of the ribs and the costal joint. So this is also very important, where the thoracic flexion is restricted, or where the thoracic flexion is restricted, or where the lateral flexion. So in this also, the biomechanics of even one thoracic spine itself, it gives the different kind of biomechanics in 3 parts according to their articular structures. And this is also the orthokinematics of in the flexion. Like yesterday, we also saw this type that how in the flexion, the body of the superior vertebra, this is the superior vertebra, this is the inferior vertebra. So superior vertebra, how it is tilting anteriorly, it is coming anteriorly, translate anteriorly and rotate slightly on the adjacent vertebra, inferior vertebra. So it is coming on the inferior vertebra. So it is coming just like a gliding or tilting, just like something is falling, because it is a flexion position. And same when it will be the extension position, it will be the opposite position of that particular, the superior uh, movement will be the different. In this also, the superior vertebra tilts and translate posteriorly, and the inferior articular facet guides downward on the superior. So it means the movement same, the way here the flexion is there, and in the extension same, the opposite will be followed, the rule of the biomechanics of inflection to the extension. So that is also in this also we can see where the compression is coming. So it means, sorry, it means that the ligaments which are anteriorly present, how it is getting compression, and the ligaments which are in the posteriorly, how they are getting the stretch. So this is also a very important thing that in the flexion and extension, how the biomechanics of ligaments, how the biomechanics of the muscle attachment with the muscles which are attached with the thoracic spine, the muscles which are playing a major role if the patient is having a frozen shoulder, if the patient is having a shoulder impingement. So how the movement of the thorax plays a very major role whenever, like in yesterday's session itself, sir has explained that how whenever if we treat the thoracic spine, give the mobilization to the thoracic spine, so the patient will be benefited with the range of motion of their shoulder also, or as well as the patient is having a cervical spine. So how after giving the manipulation to the thorax, the cervical spine movement will be more easier than the restriction. So this is the way the biomechanics compensate with each other also in the one region to another region. And this is also the in the flexion position of the thoracic spine, where also you can see that the line of gravity is coming from the cervical spine. So anterior, there is a concavity of the thoracic spine. Thoracic spine places with the central of gravity of the head, and the cervical spine anteriorly, much of the thoracic spine. So in this also you can see that how the flexion is coming. And if we talk about the extension movement, it can be exerted by the extensors muscle also, by the posterior ligament. If the patient is having a kyphosis, in this also you can see that the kyphosis increase the external flexion movement, and the resulting internal extension movement increase, producing reaction force on the vertebral body. The patient is having a kyphosis itself, but if there is a line of gravity is coming from the cervical spine. But in that, in the movement of that thoracic spine, the vertebra which is inside the spine, that is also, they are taking their movement of the flexion and extension. So during the kyphosis also, they are matching with the line of gravity, or it increase the compressive forces on the vertebral body also, because the patient has adopted, or the more kyphosis is coming, but that time also the vertebra is doing their movement in the as an internal or external flexion movement and the extension movement. So in this also the reaction forces on vertebral body are working. So this is the way that if the patient is having maintaining, the patient is having a slouching posture, or they are using the online work they are doing. So after that, they are just keeping every time the neck is in the cervical spine is the bending position, so that the compensation taken by the scapula also, or because of the anterior tipping of the scapula also. So that time also the thoracic spine maintain the kyphosis. For that, these forces work on the vertebral body that time also. So if we this in this position also, if we mobilize or the manipulate that thoracic spine, so it relieves the cervical spine also. The patient gets the relief in there. Or if we work on the active forces like the muscles which are related to the for the elevation of the shoulder, or we work on that particular active part of the kinetics of that region also. so patient get relief. So this is all about that how we can understand that we cannot treat only the simple articular structure. All the structures are also working together. So we have for maintaining the kyphosis or maintaining the slouching position itself, the posture correction itself needed, or as well as the active forces, the muscles plays a very major role. That is also very important here. Or if there is a because of this there is a impingement, so that is also important and during the evaluation of the mechanics of thoracic spine. And this also you can see that the flexion and extension of the thoracic spine and the weight bearing, like in the sitting position or in the standing position, we can check it according to the gravity. We check in this also with the spinal, the erector muscles which are in the posteriorly, the eccentrically controlling the descent, like the patient is going in the flexion position, that time the erector spine muscle that's giving the force to controlling the thoracic spine. Or if we are checking for the extension of the thoracic spine, so it is also produced principally with the lumbar spine extensor and result in the inferior glide of the superior facet of the zygophysial, which we have already seen in our previous slide, that how the extension in that the zygophysial joint work, and 1 or 2 degree of extension is available in each the thoracic segment, which giving an overall average of 15 to 20 degree of thoracic extension for the thoracic spine. So it means that if we are checking in the extension position itself, so the articular, the facet joints, the zygophysial joint, how their superior and inferior facet articulate with each other in the extension. So it means they are pressing the gliding on adjacent vertebra. Or if we are doing the flexion position, where the role of the eccentrical control of erector muscles plays a very major role to maintain the line of gravity of the body also. Or if there is a during the bilateral scapular protraction is coming with the flexion also, so we have to maintain that also. So this is all about the flexion and extension of the thoracic spine. We have to check all the scapular movement also, the lumbar spine, or the muscles which are present, the erector spinae, or if the breathing we adding with the core muscles are also, or the diaphragm, that also plays a very major role while evaluation the biomechanics of flexion and extension of the thoracic spine. And this, the lateral flexion, how it moves, that is also a very important part, that yes, to the right side, like in the lateral flexion to the right side, the right inferior articular facet of the superior vertebra. This is the superior vertebra, this is inferior. In this also the superior vertebra, the inferior articular facet of the superior vertebra glide downwards the right superior articular. It means that lower part is articulating on the downward, the adjacent vertebra upper part. Means this is the downward or this is the upper part. So they are articulating on the each other. This is the downward of upper part. This is the upward of downward vertebra. So it means they are articulating with each other in the lateral flexion also. Like the flexion is going on the right side, so they are articulating, or the contralateral side, if this side they are working, but on the contralateral side, that is the opposite side, the left inferior articular facet of the superior vertebra, that opposite action will be happening there. That inferior articular facet of the superior vertebra glide upward, that was going in the downward movement, and this will go in the upward movement on the left superior articular facet to the adjacent inferior vertebra, that you can see in this. Like in this, the right lateral flexion is going on, so it is moving, the inferior articular facet is moving on the superior articular facet of the adjacent vertebra. This, or if I will say that we will see the contralateral side, then you can see that how it's the moving the the left inferior articular facet of, this is the upper the superior vertebra, inferior articulate process, it glides upward, because it is going up, this is going downward, and this is coming upward. So it is coming, so it means there is a gap is coming in between the opposite side. There is the compression is coming, or there is a stretch will be come in between where the stretch will come, the ligaments which are in between the transfer process, that ligaments will get the stretch there, because there is a contralateral side, opposite side, that inferior articular, the facet, articular facet, that is going in a upward direction. So it will give the, maybe they can be in the taut position, they can come, or they can be in the slack position, it will not hold the properly. So this is the biomechanics of the particular vertebral bodies of thoracic spine, or the vertebral body, all they, when they do the lateral flexion, so the same gliding happen in the one side, or in the contralateral side, there is a gap will be come. So it means if the patient is having the problem, the narrowing of the foramen, also the facet joints, the transfer foramen, also like in the cervical spine we have seen. So it means there is a patient is having a unilateral side numbness symptoms can become, or the patient is having the trigger points on the unilateral side also, because of the laxity of these ligament which is present, or it may be because we are talking about the facet joint, there can be a lock can become, maybe the flexion lock, maybe the extension lock, it can also be possible. On in that time, if we are coming back to the biomechanics, to our session, which is the pre-congress webinar for the CHIROCON, where we are going to learn, improvise our knowledge with the tool, activator tool, or the gun. So it means we have to give that impulses on that places where the lock is, the facet joint is in the lock position in the unilateral side, or maybe with the contralateral side with the lateral flexion. So this is the way where we are going to give our forces on the spinous process, where we will give our impulses on the transfer direction, where we will give on the, if there is a facet syndrome, so where we will give our impulse on the facet joint by seeing the biomechanics of these facet joints with the contralateral side or the same side. And if there is a axial rotation is going on the superior vertebral, rotates on the inferior vertebra and the inferior articular surface of the adjacent inferior vertebra, the same like in the lateral flexion, we have seen the same like in this also example in rotation to the left. If the patient is going to rotate on the left side, the right inferior articular facet impacts on the right superior facet on the adjacent vertebra. The same thing like in the lateral flexion, the same in the axial rotation also, it will articulate, these joints will play a very major role, they will articulate on each other, the inferior part of superior vertebra or the superior part of the inferior vertebra. So this is the mechanism work either in the axial rotation or in the lateral flexion. It means the SI or IS, it will work the superior, inferior, and inferior, superior. So it will, we will learn like this, that we can easily understand that. So that how the superior, inferior articulate and inferior, superior articulate, it we can be matched, and we can keep remember like with the lateral flexion and the axial rotation. And this is the rotation and gliding motion occurs between the ribs and the vertebral bodies at the costovertebral joint. So this is also because we are talking about the biomechanics of the thoracic. So it means it is also very important that how movement is going to happen with the vertebral bodies, which is related to the costovertebral joint with the attachment with the ribs. Anteriorly, there is a presence of the sternum, and the posteriorly, there is the costovertebral joint that is also rotating. So it means we have to check either the movement with the movement testing, or either with the breathing pattern. We check with the both the things simultaneously. And this is also a slight amount of rotation on the surfaces of the ribs, as well as this is for the, like we saw the facet articulation of the transfer processes there. And this is the costal. You can see with the vertebral body how it is attached. So this movements at the costal joints are primary for the ventilation of the lungs, but it also allow for some flexibility for the thoracic region. So it is attached with the vertebral body. And when we check with the breathing pattern, so it provides the ventilation to the lungs also, and the flexibility of the thoracic spine also, because when these will be moved, so it will give the flexibility, because if they are tight, they will tightly close the thoracic spine, they will not allow the movement. So if they are in a ribs are in a proper movement, their functioning is going on with the exhalation and inhalation, ribs are working properly, so it will give the flexibility to the thoracic spine also. So it means if sometimes the patient is having a dysfunction related to thoracic spine, but we miss that maybe the dysfunction related to the ribs dysfunction are there, or the mechanics of the ribs we never check, and we only just see that the patient is having a pain in thoracic spine. We give electronic modalities, we give ultrasonic, but we never palpate and we never move towards from posterior to anterior. We never see that and there is a ribs which are present posterior to anterior. We have to palpate that also. Or and superior to inferior, there is a sternum also that is also attached with the thoracic spine. So these are the movement testing of the thorax, where the anterior, the superior anterior we check for the sternum, or for the posterior to anterior we check for the ribs also. Or if the posterior, the costovertebral joint that is present in the posteriorly, patient say only the pain is only there that in the posterior side, that we check with the movement testing for the thorax spine. After that, this was the part of the kinematics, but in this thorax, the kinetics also plays a very major role, where the main breathing muscles which are attached to the thorax spine, that plays a very major role, and it provides the stability to the thorax also. So in that also, I will say that to release the diaphragm, it gives because the diaphragm kinetics, the working of the diaphragm is completely it compromise if there is a thoracic dysfunction, or if there is a tightness in the diaphragm, the patient will not be able to move their the movement of the thoracic spine, because they feel pain while they will maybe in the lateral flexion or maybe in the extension flexion, because the exhalation and inhalation completely we see with the ribs as well as the diaphragm dysfunction. So this is also the part of as a kinetics, we have to see the biomechanics of the diaphragm also, that how with the inhalation and exhalation the diaphragm flattened, and in this also during the inhalation the diaphragm presses the abdominal organ and downwards and forward. So the action of the rib cage is in the inhalation, it means it will expand, or if the action of the during the exhalation, the rib cage will be in a closed position. So it means that how the inhalation and exhalation, during exhalation how the with rib cage becomes, and during the inhalation how it becomes. So with that, the diaphragm, how the diaphragm is a dome shaped or with the flattened shape according to the inhalation and the exhalation. So it means we sometimes the release of diaphragm, like as a part of the myokinetic, the release of the diaphragm itself give relief to the other part of the pain. So it means there is a completely a chain which is also connecting. So we will not only think about the thoracic spine, the articular dysfunction on the kinematics parts, we have to see the kinetics also, where these the breathing muscles plays a major role, because these muscles are completely associated with the rib cage also. So if the patient is having a pain in the ribs or in the thoracic spines, we have to see the biomechanics of the diaphragm also. And these are the muscles for the forced inspiration. These are muscle like in our serratus posterior muscles, the levator muscle, longest muscle, and the costal brevis muscle, posterior muscle, and the quadratus lumborum muscle for the lumbar spine. And these are the full the erector spinae muscle, how it plays a major role in a different part of the spine from cervical thorax to the lumbar spine. And these are the muscles of our abdominal muscle, the transfer abdominis, internal oblique, external oblique, rectus abdominis, because their attachment to the sternum. So these muscle also plays a very major role as a kinetic part of the biomechanics of the thoracic spine. And yes, the scalenus muscle, anterior, middle, and posterior, that also their attachment with the insertion in the first rib and the second rib, and they elevate the upper ribs and the sternum. So it also a part of the evaluation of the thoracic spine. We cannot forget these muscles also as a part of biomechanics of the thoracic spine. And this is also this I have packed with all the how we can, the costal muscles which are also related with the thoracic spine, how we can move, how we can check these intercostal, the external and internal costal muscle with the breathing, by keeping our hand with the grip, that with the web space, how we will move, because we know that there's a space between the ribs. Like this is the rib, so there is a space like a web space, like, so how we can keep our hand, we check with the inhalation, exhalation, with the movement of the thoracic spine, how the posterior vertebral, the costal vertebral is giving a pain to the patient, or the exhalation and inhalation during that, how ribs are moving in the superior position or in the inferior position, or in the sitting sit to stand position with the movement of thoracic spine. So these are the things that is also the part of our thoracic manual therapy, the specialist course for the thorax. That is also this part of this costal muscles also plays a very major role in the biomechanics of the thorax, because of the movement itself of these muscles, their fibers, muscle fiber attachment itself gives that how the external costal muscles plays a major role in the inhalation, and the internal costal muscle plays a very major role in the exhalation according to their fiber orientation in the ribs. So for this also, that these mechanics is also very important. So like this, you can see that in the intercostals, that origin with like same which I was showing with the sir practical demonstration. So how the external and internal muscles fibers, they are attached. It elevate and depress the ribs, stabilize the internal costal space, and prevent an inward collapse of the upper thoracic wall. Or these are the all muscles, the true core muscle that is also plays a major role with the biomechanics of the thoracic spine, the kinetic part of the thoracic spine, that four abdominal muscles, diaphragm, erector spinae, multifidus, and the pelvic floor muscle. So these are also correlated with the thorax and the chest wall. So we cannot forget the biomechanics of these muscles, that how it can be in overactivity or underactivity at one place, or because of that the patient is having a pain in the thoracic spine. And this is all of our course, the thoracic spine course, which I captured and saved in for my memory, that how we worked the evaluation, biomechanics, pathomechanics, anatomy, the release, or the manual therapy, either the MET, myofascial, fasciomuscular release, motor control retraining, which we learned in this course. This I saved for my memory in my as a PDF, so that I can anytime we can see that and we can understand that how we do the evaluation if the patient is having a disturbance in their thoracic spine, so how we can move towards that. So this is the, I will say the, I really feel blessed that when we got this type of courses, which whenever we stuck somewhere, whenever any patient comes there, we see that there is a disturbance in their movement testing. So that time we can easily open this and we can see that how we can check in a supine position, in the sideline position, in the sitting, or if the patient is having a frozen shoulder, but they are not getting relief, it means there is something is missing which we were not adding. So that time we go there and we see that, yes, I forgot to check the thoracic spine. I have not added the treatment of the thoracic spine in my frozen shoulder patient. When as I will add, I will get the best relief. So this is the way I will say that hats off to sir, that how he added all these things for our better future. So this is the way we understand about the thoracic spine. So this was all about the biomechanics of the thoracic spine, where the flexion extension limited, but rotation we check with the thoracic spine, and with the axial rotation, where the role of costovertebral joints as well as the transfer process, the facet joints plays a very major role, and they articulate with each other according to the mechanics of their superior and inferior articular process. And the ligaments as a articular part, how the one side ligaments get the compression, and another side they are getting the stretch, and where they when they are getting a compression in the flexion position, there also the disc plays a very major role. So that time also the anteriorly the upper side the disc getting the compression, and the posterior side sometimes because of the more flexion the patient gets the disc herniation, so the disc material is bulging in the posterior position. So this is the way the mechanics we have to see in which position itself patient getting relief, either in a flexion position or the centralization or the peripheralization of the symptoms during the biomechanics testing of that particular region. We see that in which direction the patient getting relief, either the symptoms are centralized, or they are the peripheralized. So maybe they are having these symptoms are going towards, if there is a lumbar spine till the lower extremity, or if there is a cervical spine, so that symptoms are radiating towards the upper extremity also, as well as the patient is having a thoracic spine problem, but they are having a pain in their arm also, or maybe they are the winging of scapula. So these are the things also correlated with the thoracic spine. So it means we can say that in the thoracic spine, there is a very important things for the biomechanics understanding of thoracic spine: the ribs, sternum, costovertebral joints, intercostal muscles that plays a very major role, as well as the muscles attachment, the primary respiratory muscles like the scalenus muscles. They can be a tight in the tight position, or maybe there is a pectoralis patient is having a tightness in the pectoralis region. So it may be the cause of the thorax also, or maybe the ribs dysfunction also, or maybe the patient is having some cardiac problem. Because of that, they are having some problem in their sternum, the pain in the sternum. So that time also that thorax, because we know that the posture related, that where the sternum and where the posteriorly there is a thoracic spine. So it means because of that, there are the ligaments which are also attached as a visceral part. They are also attached with the sternum to the thoracic spine. So we cannot forget these things also, as a visceral also, as a somatic also. We cannot forget these evaluation. But how we can move towards it after understanding of the anatomy, the applied biomechanics, that how we check it, all these things for the thoracic spine. So this is the all way. I don't think that thoracic spine is so easy. It is very, very difficult for me also. But after learning from sir, or after this course, this biomechanics of thoracic spine become easy. Not, I will not say it's still not easy, but yes, comparatively it is easy for me. But I will say that understanding of thoracic spine or treating the thoracic spine is very, very mandatory. And from how we are going to treat, that is very important. Either we are using the manipulation or the mobilization of that particular area, the thoracic spine, that is also very important. So now we covered that how the thoracic spine, all the parts, the kinetics, kinematics, or as well as the uh, how we as a clinician, we applied biomechanics in our evaluation and the testing as well as the assessment. After that, we are moving towards the lumbar spine.
Yes, Ritu ma'am, just hold on.
Yes, sir.
Or I should stop it and start again.